First, let me apologize for going so long in lecture today. I got a little sidetracked by all of the interesting statistics, but let me see if I can go over the remaining portion of the lecture for you in a little bit of expedited format. We'll start with the section on initiating antiretroviral therapy. As you can see from this slide, antiretroviral therapy is recommended for all HIV-infected individuals. The strength of the evidence varies, but the conclusion is that it should be given both for therapeutic reasons in the individual patient as well as to prevent the transmission of HIV, as you can see here. And this provides a great public health benefit. In order to understand the HIV drugs, one needs to understand clearly the life cycle of the HIV virus. Please remember from your microbiology section that the virus attaches to the CD4 receptor as shown here through the GP120, which is present on the envelope of the HIV virus. After binding to the CD4 receptor, the virus also has to bind to a CCR5 or CXCR4 chemokine co-receptor. In the absence of this binding, either from drug inhibition from one of the inhibitors that is currently available to block CCR5, or from genetic absence of the CCR5 gene in a homozygous presentation, the virus will not bind and the cell will not become infected. The next step after attachment is fusion. This is mediated through the GP41 protein on the virus surface, and we currently have a fusion inhibitor. Once the virus fuses, it gets into the cytoplasm where 2 copies of the positive single-stranded RNA along with the functional enzymes reverse transcriptase, integrase, and HIV protease are released. Once they are released, reverse transcriptase will then convert the RNA to DNA and double-stranded DNA, and this step can also be inhibited both through nucleoside reverse transcriptase inhibitors, which work at the active site and look like nucleotides, or non-nucleotide reverse transcriptase inhibitors, which work at a site away from the active site. Once the double-stranded DNA is made, it forms a pre-integration complex, and this moves through nuclear pores and is integrated into the chromosome through the action of integrase. What's important to remember here is that this is a crucial step in the life cycle, and it integrates the viral genome into the chromosome of the host cell. In the absence of sophisticated molecular biology techniques like CRISPRs, this copy of the virus remains in the chromosome until the cell dies. At some point in time, the cell is activated and replicates the DNA to produce message, and this message either is in a full-length transcript or in transcript messenger RNA transcripts that code for messages. These are 3 different transcripts: GAG, GAG-POL, and envelope. And then these are translated, and they're translated into polyproteins where, along with the full-length virus, are assembled at the cell surface, and the virus buds off of the cell membrane. At this point, the viral RNA is intact, but the proteins exist as polyproteins, and they have to be cleaved by HIV protease, which is incorporated into this into this virus. And once the HIV protease cleaves the polypeptides into individual proteins, you get a mature virus particle. From the next 2 slides, you have a written description of what I just said, and it's important for you to remember all of these steps, obviously, as indicated in red. The transcription codes for both full-length transcripts as well as the 3 viral genes. The polypeptides are cleaved by HIV protease, and this is somewhat different than I told you in microbiology. It's recently been determined that the protease activity does not take place inside the cell surface, but after the virus has budded. In order to block these steps, we have several different agents, which you will need to remember the specific agent and the mechanism of action. But we'll only be remembering representative agents from each of the classes. So as we walk through the stages in the life cycle, we cannot inhibit currently, at least clinically, the binding to the CD4 receptor, but we can block binding to the CCR5 chemokine receptor. And this is through the receptor antagonist Maraviroc. It has been released about 9 years ago. It is metabolized by the cytochrome P453A system, so it can have a number of drug-drug interactions. What is necessary for the use of this agent is that you must determine whether the virus that's infecting the individual binds to CCR5 alone, CXCR4 alone, or binds to both strains of the virus. What happens is that you must send off a test which has the trade name of a trophile, and it determines whether the specific virus that the individual has will bind through amplification of the binding region to CCR5, CXCR4, or both. For this drug to be used, the viral isolate must only bind to CCR5. Should it bind to CXCR4 or both, this agent becomes useless, and it only adds expense and toxicity to the regimen without having any efficacy. We have a fusion inhibitor, enfuvirtide, which functions by binding to the region of GP41 that is responsible for the folding back of the protein on itself and fusing the 2 cell membranes. The drug itself is a polypeptide, and therefore, because this drug is degraded rapidly through gastric absorption, it must be administered like insulin sub-Q, and it must be injected twice a day. It is both expensive and has a significant number of local reactions, and therefore this drug is not routinely used and is a third-line regimen for patients with highly resistant virus. The nucleoside reverse transcriptase inhibitors we talked about in microbiology in the first year, but I'll go over these again. The natural bases deoxythymidine, cytidine, deoxyadenosine, and deoxyguanosine all have a 3' hydroxyl, as you can see here. And at the 3' hydroxyl site, this is where the next base is added through the linkage, and all of the nucleoside reverse transcriptase inhibitors look like the native nucleoside, but they have either a modification or no 3' hydroxyl, as you can see in each of these structures. The original compound, zidovudine, has the chemical name azothymidine. For N3 is an azo group, and this is thymidine, so it's azothymidine, and that's where the abbreviation AZT comes from. These nucleoside reverse transcriptase inhibitors, NRTIs, are taken up and mono, di, and triphosphorylated in the uninfected and infected cells. These nucleoside triphosphates competitively inhibit reverse transcriptase, and they also do inhibit the DNA polymerase of cells, but they are 100-fold more active against reverse transcriptase than the cellular DNA polymerase. Once these compounds are incorporated by reverse transcriptase, they block the addition of the next nucleotide by absence of the 3' hydroxyl, And so their mechanism is chain termination, as indicated here. This is the diagram you've seen before on chain termination. The 5' phosphate is added to the 3' of the base that's being added, and then this hydroxyl becomes the site of attachment for the next base being added. If this hydroxyl is absent, as in the case of the nucleoside reverse transcriptase inhibitors, the reaction will not proceed, and this results in chain termination. The nucleoside reverse transcriptase inhibitors can be coded for resistance by a single nucleotide change within reverse transcriptase. This provides a significant problem and was a major impediment in the first drugs that were introduced for HIV, mainly because zidovudine or AZT can become resistant with a single nucleotide change, and since reverse transcriptase has a low fidelity and there are over 10 billion particles per day made, if you give an agent which only requires a single nucleotide change, you can rapidly select for resistance, and that's what happened in the initial stages of treatment of HIV when only 1 or 2 drugs were available. The nucleoside reverse transcriptase inhibitors have class toxicities. All of them can produce a lactic acidosis and hepatic steatosis. This is thought to be related to their enhanced toxicity in certain people for mitochondrial DNA. These agents may totally inhibit mitochondrial DNA, resulting in an anaerobic type environment with production of lactic acidosis and significant hepatic injury. Many of these agents have similar toxicities, and so the combination of 2 agents with the same toxicity will result in overlapping toxicities. And these agents are probably also responsible for part of the lipodystrophy seen in patients with HIV, where they may either have lipoatrophy, the thin, gaunt, drawn-out faces, or they may also suffer from increased fat deposition, the so-called dorsal fat pad or buffalo hump, as well as adipose tissue around the abdomen, similar to patients with Cushing's disease. Many of the agents have significant toxicities, and the ones that I wanted to point out to you particularly was abacavir. This drug has a particular toxicity, which is a rash or maybe some hypersensitivity reaction on the first administration, which if the patient continues, or especially if the drug is stopped because of the rash and rechallenged, the rechallenge can be a fatal hypersensitivity reaction. This is only seen in patients with a specific HLA determinant, HLA-B star 5701. This is also the determinant that increases the inflammatory reaction and may result in lower HIV viral loads. But this must be checked, and patients who are HLA-B5701 positive may not receive abacavir. There's also an increased risk of cardiac disease in patients on abacavir. The nucleotide reverse transcriptase inhibitor that is commercially available is tenofovir, and it is a nucleotide agent because it is already monophosphorylated. This was the first and currently only available nucleotide agent. It has excellent activity against HIV, and you may remember it from the hepatitis B lectures as well, because it is active against both. It has a great pharmacokinetic capability in that it has once daily dosing. The original formulation, the disoproxyl fumarate, was associated with renal toxicity and osteoporosis. The newer formulation, tenofovir alafenamide, has much less renal toxicity and osteoporosis, and basically all of the formulations will be converted to alafenamide, but each must undergo approval by the FDA because they are new drugs, and each of the combination therapies containing tenofovir has to have new tablet formulations approved by this FDA. Almost all of them have been converted at this particular time. We can also inhibit reverse transcriptase at a site outside of the active site and these are the non-nucleotide reverse transcriptase inhibitors. They do not look anything like nucleoside analogs. They were originally thought to be less efficacious than protease inhibitors, but they actually do work quite well. These are example of non-competitive inhibitors because they do not bind to the active site. The drug I would like you to remember here is efavirenz. It has a once daily dosing. Both resistance to efavirenz will cause resistance to both the other drugs, nevirapine and dolaverdine, but the second generation drugs, etravirine and rilpivirine, retain activity in most cases against efavirenz resistant mutants. I don't care that you know the second generation agents. Efavirenz is the one that will most likely appear on the step 1 examination, and patients receiving the second generation agents clinically, I'll ask you to just look these up again when you have them in the clinic. But for the exam and for step 1, almost all of the questions would deal with efavirenz. The major toxicities of efavirenz are central nervous system activity, in that it causes significant problems with somnolence and vivid dreams, and so the drug is generally given at night to prevent it from causing severe sleepiness during the day. The integrase strand transfer inhibitors, or the integrase inhibitors, are a major advance in HIV therapy, and the initial one was released in 2007. That was raltegravir. The drugs are remarkable for the fact that they have very little toxicity, and at least raltegravir was not metabolized by cytochrome P453A. And this drug shows excellent activity, and this class of drugs is actually the currently recommended first therapy in patients for HIV in combination with tenofovir and tricidabine. The drug I'd like you to remember, in addition to raltegravir, which was the first drug, is dolutegravir. That's because this drug is the most recently released. It is once daily, it has no interference by food or drink, and it has excellent data. There are fewer failures in patients treated with integrase inhibitors or integrase strand transfer inhibitors, is the formal name, than patients treated with protease inhibitors or non-nucleoside reverse transcriptase inhibitors because of side effects. In addition, dolutegravir is remarkable in that it requires multiple mutations to become resistant. The reason why this is important is that, as I told you with the nucleoside agents, where a single nucleotide change can confer resistance, what we're trying to do in combination therapy is force the virus to have multiple changes, multiple nucleotide modifications to occur simultaneously to develop resistance to multiple drugs. Dolutegravir itself requires multiple mutations for clinical resistance to be seen. And when you combine that with two other generally nucleoside agents, which each require separate mutations, that requires a random event which changes multiple nucleotides at the same time. Logistically, this is a very uncommon event, and that's why the combination therapy of highly active antiretroviral therapy includes multiple agents with different areas or nucleotides responsible for resistance. And the chance of this happening by chance alone at multiple sites becomes extremely low. Lastly, the protease inhibitors, which had been one of the agents that was responsible for that dramatic drop in mortality, are the last class of drugs. We have several drugs that are able to inhibit HIV protease. HIV protease is simply an aspartyl protease, just like renin, but it has very specific cleavage sites for HIV polyproteins. These are probably not unique because there are metabolic abnormalities seen in patients on HIV protease inhibitors, suggesting that there is some interference with human proteases as well. The major adverse effects of the protease inhibitors are that all of them inhibit the cytochrome P450 system. Some of these drugs are the most potent cytochrome P450 inhibitors that we have. Many other drugs that patients with HIV are on will be metabolized by cytochrome P450, and therefore these drugs have a significant degree of drug-drug interaction in these patients. Initially, it was thought that the lipodystrophy and other diseases of lipid metabolism seen in patients were exclusively related to PIs, but it is probably more closely related to the NRTIs like stavudine, DDI, and other agents. Here's a list of the protease inhibitors, starting with sequinavir. This is a time sequenced order. Sequinavir was the first, darunavir is the most recent protease inhibitor, and this is already about 10 years old. What should be noticed is that the major side effect of all of these is inhibition of cytochrome P450, but many of them have specific interactions. What you'll notice is that there is one combination, lopinavir-ritonavir, which uses ritonavir, which was the second protease inhibitor released, but ritonavir is not given here to inhibit HIV protease. Ritonavir here is given to increase the half-life and increase the serum concentrations of lopinavir, and it is a concept referred to as boosting, which I'll talk about in a second. The protease inhibitor that I'd like you to remember is darunavir, and it is the most active, and it can be given twice a day if you give it with ritonavir to boost the levels of the co-administered protease inhibitor, in this case, which is darunavir. Boosting is a concept where you increase the level and half-life of the protease inhibitor by inhibiting cytochrome P453A. Prior to a few years ago, the agent that was exclusively used to do this was the protease inhibitor ritonavir. Ritonavir is a good protease inhibitor, but at doses that are required for inhibition of HIV protease, there's a significant degree of GI and other intolerability. So it was not a great drug as an HIV protease inhibitor. But in terms of its ability to inhibit cytochrome P453A, it is probably one of the most potent CYP3A inhibitors. And when given in low dose, it can, quote, boost the effect of the co-administered HIV protease to allow for increased drug levels and increased half-lives, which allow you to have a therapeutic drug level for a longer period of time. It can convert 3 and 4 times a day drugs to twice a day and once a day drugs, as it does with darunavir, making it a once a day administration when boosted with ritonavir. A new drug was recently developed 3 years ago called cobicistat, and it was given the title of a pharmacoenhancer. It's an analog of ritonavir, but it is totally devoid of HIV protease activity. This is actually beneficial because the low doses of ritonavir could select for mutants of HIV protease, but since this drug, cobicistat, has no HIV protease activity, it does not influence selection of resistance. The drug itself is metabolized by cytochrome P453A, but the metabolite irreversibly inhibits CYP3A activity. It was originally introduced as part of a 4-drug pill which combined 2 nucleoside reverse transcriptase inhibitors, tenofovir and emtricitabine, along with a integrase inhibitor which was metabolized by cytochrome P453A, and that's why cobicistat was added. 2 years ago, the drug was introduced as a single agent, but please be aware that it does not boost all the protease inhibitors to the same extent, and when it's given, it must be selectively added to particular agents. What I'd like you to remember from all of this are the medication that appear below. so that the CCR5 receptor antagonist is Maraviroc, and that you must know that you have to test the virus for receptor affinity, even when it's spelled correctly. The fusion inhibitor is Infuvritide. It has severe local reactions, is subcutaneous, and is quite expensive. The nucleoside reverse transcriptase inhibitors that are currently used, I want you to remember two. This is the nucleotide tenofovir. It's included in this even though technically it's a nucleotide, and emtricitabine. Both of these drugs are chosen mainly because they are, one, both quite active, but two, they have significantly enhanced half-lives, and both of these drugs can be given once a day. Tenofovir has problems with both the kidney and bone, but the alafenamide formulation, these were all done with the diazoproxil fumarate formulation. The alafenamide formulation is probably less toxic. Emtricitabine has very little toxicity, and as a benefit, both tenofovir and emtricitabine have hepatitis B activity. The non-nucleoside reverse transcriptase inhibitor efavirenz has mainly CNS effects. The integrase inhibitor that I'd like you to remember is dolutegravir. It has few adverse effects, and it's highly active, requiring multiple mutations for development of resistance. And lastly, the HIV protease inhibitor I want you to remember is darunavir. I left off this list the enhancer, the boosting agents of both ritonavir and cobicistat, but please remember those as well. These are the specific HIV meds that you need to remember. What do you start in somebody who has been infected with HIV and you want to start an initial regimen? This is the data from the last time it was reviewed in July of 2016. Please note that the guidelines follow a pattern somewhat like my notes. These volumes are about 200 pages long, and what they do from version to version, if there has been if there's been any change, the changes will be highlighted so one can rapidly go through and see where see where the changes are. The current preferred regimens are the integrase strand inhibitor regimens, which include dolutegravir plus either two nucleoside reverse transcriptase inhibitors, abacavir, lamivudine, or most people use dolutegravir plus tenofovir and emtricitabine. When all the formulations of tenofovir are converted to alafenamide, this will be tenofovir, alafenamide, emtricitabine. So that a integrase strand transfer inhibitor or an integrase inhibitor is combined with two nucleosides, generally tenofovir and emtricitabine, or abacavir lamivudine, but please remember with abacavir the patient has to be HLA-B5701 negative. There are other regimens. I don't care that you remember the one that contains cobicistat. I'd just like you to remember cobicistat for the fact that it will boost levels. The general principle I'd like you to remember, and that will be necessary for the boards because these recommendations change so frequently, will be the design of the regimen, not the individual drugs. Currently, it's a integrase strand inhibitor plus two nucleoside reverse transcriptase inhibitors. The protease-based regimen, there's one regimen, the darunavir-ritonavir combination for boosted ritonavir, plus once again you'll see the tenofovir emtricitabine. So both clinically and for the boards, the nucleoside reverse transcriptase inhibitor combination that's most effective and most widely used is tenofovir emtricitabine, and that is generally combined with a integrase strand inhibitor, but you can also construct as an initial recommendation a tenofovir emtricitabine plus a protease inhibitor. In this case it would be darunavir ritonavir, and it must be boosted so that the levels are high enough. Why you would select one versus the other is really a clinical decision, and there may be reasons why you would want to use a protease inhibitor instead of an integrase inhibitor, but nearly everyone these days is started on integrase inhibitors, especially dolutegravir, because of its much more marked resistance to mutations at the integrase. And these regimens are quite durable, and my guess is these recommendations won't change for a period of time. Lastly, we're going to talk about how HIV transmission can be prevented, and here we're going to get into transmission during childbirth, which fits right in with the reproductive module as well. Without any antiretroviral therapy to the mother during pregnancy, labor, delivery, the fetus has about a 15 to 25% chance of developing HIV, and about a 25 to 35% chance in developing countries. So not all children born to HIV positive women, even without therapy, will have HIV. Only about a quarter to a third in the United States, and up to a third worldwide. HIV viral load is clearly a significant risk factor. So in a series of 552 single pregnancies, the rate of transmission from mother to baby was stratified by their viral load. 40% of women with a viral load of greater than 100,000 passed along the virus to their child, and you can see the different levels here, whereas women with less than 1,000 copies of HIV, the transmission was 0. You should not take this as an absolute, because there may be no threshold below which transmission will never occur, but you can clearly see that as the viral load decreases, the transmission decreases. Zidovudine was introduced when it was the only agent that had been tested in pregnancy, and it had been begun in the second trimester through delivery, and for the infant for 6 weeks following birth. When done in this fashion, and this is initially with just zidovudine, it reduced the transmission from 22% to less than 5% in the untreated group. Recently, and I'll show you the recommendations once again from the AIDS Task Force, this reduction is probably even better with women treated with combination therapy. The original recommendation for zidovudine was because the teratogenic potential of some of the agents had not been fully assessed, and some initial data suggested some teratogenic properties. However, this is no longer the case, and most women are recommended to start on combination therapy, as I'll show you in just a minute. What's also interesting is that couples who are discordant with HIV, who want to conceive, either both couples or discordant couples, can receive HIV therapy to try and conceive a child who has very low risk of HIV and without infecting the other partner. And as you can see from these recommendations, they should be counseled and only attempt conception after the HIV-infected partner has initiated antiretroviral therapy, and you can document that there's a viral load below the level of detection. This will not, I repeat, not be 100% protective, but the rates of transmission when the viral load is below the limits of detection is extraordinarily rare. The administration of the pre-exposure prophylaxis should be 30 days before and 30 days after conception in the HIV uninfected partner. You can continue to, it's really not known whether pre-exposure prophylaxis for the uninfected partner can confer as additional benefit. But for discordant couples, there is a mechanism for allowing pregnancy which decreases the risk for the uninfected partner. For intrapartum antiretroviral therapy, for women who have a known viral load of greater than 1,000 copies, whether they are on medications or not, they should receive zidovudine near delivery, but it is not required for women who have a viral load of less than 1,000, taking from the prior data. In addition, cesarean section should be considered at 38. Should be performed at 38 weeks gestation, compared to 39 for most indications for women who are viremic, and this is because natural childbirth increases the risk of virus spread compared to cesarean section. There are several things in women who are viremic that should be avoided. Artificial rupture of the membranes in the setting of viremia, routine use of scalp electrodes because this introduces the risk of bleeding, operative delivery with forceps or vacuum extractor, and episiotomy should be avoided routinely in women that have a viral load. Lastly, all HIV-exposed infants should receive antiretroviral therapy, and it should begin within 6 to 12 hours of delivery. Now the recommendation is for 4 weeks of zidovudine therapy for full-term infants, where standard antiretroviral regimen during pregnancy has a sustained viral suppression, and there are no concerns related to maternal adherence. Otherwise, a 6-week course of combination infant prophylaxis is recommended. The summary of these prenatal recommendations, even when it's spelled correctly, should be that all pregnant women should be tested and initiate therapy if the results are unknown. Current data suggests that no increase in birth defects, and recommend that women initiate therapy during pregnancy and continue throughout pregnancy. And now multiple drug regimens are being recommended and used. Rapid testing should be done in women with no prenatal testing, and if it's positive, intravenous zidovudine should be given if the woman is in labor. And then once the positive salivary test is determined, or even a blood test is antibody positive, you should go ahead with direct amplification, because there are problems with false positive ELISAs, especially in pregnancy. And you should stop if both the antibody or the direct amplification are negative. The reason for this is you need to do direct amplification to make sure that the woman is not in the acute retroviral syndrome stage, where the antibody is going to be negative but the direct amplification is positive. Women with viral loads of greater than 1,000 copies should receive zidovudine. So if a woman comes in and you don't know what her viral load is and she does not have a non-detectable load, they would be started on zidovudine. You could get the viral load and then determine whether or not it needs to be continued. Children born to women with viral loads of greater than 1,000 or possible HIV viremia should receive 1 month of zidovudine. And I really had problems with spelling here. Schedule cesarean section at 38 weeks for women with viral loads of greater than 1,000 copies. The success of this regimen is astounding. From 1997 to 2015, in 1997, 99 infected infants were born in New York State. And this is I believe this is nationwide data. But if you look at this rate, let me just double check here. 97, yes. It says 99 infants were born. There has been a marked decline, and in 2013 and 2015, New York State met the CDC criteria for elimination, and that there was less than 1% of the exposed infants, or less than 1 case of mother-to-child transmission for 100,000 live births. And this is a staggering success of this prophylactic regimen. So one way is perinatal transmission can be prevented. You can also prevent transmission of the virus by using pre-exposure prophylaxis. If you're going to engage in high-risk sexual exposure, in this case generally men having sex with men, If you're HIV negative and are having sexual activity with men who you do not know their risk factor or HIV status, it will significantly decrease the transmission with low but not zero risk. It is highly effective, and it can also be used for discordant couples where one of the couple members is HIV positive. It can be given in the HIV negative individual to prevent transmission, and obviously you would decrease the risk by trying to get the viral load in the HIV positive individual as low as possible. And as I showed you before, it can be used in conception. The pre-exposure prophylaxis in terms of men having sex with men, in men given placebo, the risk of infection, this is just an amplification of this area of the diagram, was significantly increased in those given placebo versus those given tenofovir plus emtricitabine. So that you can see that the cumulative probability of HIV-1 was less than 2% compared to around 14% for the placebo. Lastly, for the next couple slides, non-occupational post-exposure prophylaxis can be given in individuals who have received non-occupational exposure, generally unwanted sexual intercourse or sexual intercourse that the individual is concerned about developing HIV from a partner of unknown status. This is given as combination of meds, generally including tenofovir, emtricitabine, and an integrase inhibitor. You don't need to know the details, but once again, it's the therapy, it's the concept of highly active antiretroviral therapy, 2 nucleosides and an integrase inhibitor. Or occupational post-exposure prophylaxis, where a healthcare worker sustains a needle stick injury or other exposure to blood and blood products, either through oral or splash to the eyes and conjunctiva. Once again, this is the same combination of an integrase inhibitor, which is raltegravir in this case, plus tenofovir and emtricitabine. These regimens may be modified. This is the one that is currently approved in New York State, but I don't think that there'd be any problems with substituting dolutegravir for raltegravir. Lastly, the new developments, there are clearly long-acting injectables which have been shown to work in the simian model of immunodeficiency virus, and these drugs can last for up to a month, and so that these could be monthly injections to prevent the development of HIV. They are not currently available, but they could be given in a fashion similar to birth control medications with injectables lasting a month. Lastly, you may have heard about the cure of the so-called Berlin patient. This was a patient who had HIV and AIDS, who developed acute myeloblastic leukemia and needed a bone marrow transplant. The patient prior to therapy was a delta 32 CCR5 patient, and in other words, he had a delta 32 deletion of his CCR5 in one copy and had an intact CCR5 in the other copy of the gene. That's what this looks like on the restriction map. If it were homozygous for the delta 32, you get this band. So the patient before stem cell transplant had a one copy of the CCR5 gene. He got transplanted with a CCR5 homozygous individual, and post-transplant was CCR5 deficient. He was treated with drugs for several months after his transplant, but then the drugs were stopped, and it's the current time he has been HIV-free off of medications for about 6 years now, I believe. So you could imagine if we could develop highly effective drugs with very long half-lives that blocked CCR5 and hopefully both CCR5 and CXCR4. These may be the gateway to single drug, highly active regimens, which would block entry of the virus into the cell, and you don't even have to worry about the concept of development of resistance because you never get infection.